I'm a consultant uro-oncologist at Rajiv Gandhi Cancer Institute. We are the largest cancer center in the private sector in the country. I have no conflicts of interest to disclose. So I'll be talking about tumor in a difficult location of dome and posterior wall. Now, people tend to assume that resecting dome and posterior wall would be difficult because of the angles of manipulation, what we know as kinematics. But however, when we did simulation studies with robots, we found that dome is actually the easiest area of the hemisphere. It is easiest to resect, and kinematic angles there are actually the best. The most difficult area is actually at the equator in the posterior wall. So what exactly causes problem in resecting at the dome is not the kinematic angle, but actually the distance, because dome becomes the furthest point from the bladder neck, and that is what creates your problem. If there is bleeding and you increase the irrigation fluid to control that bleeding, then dome recedes further away from you, compounding your problems. Plus, your room for error is low because the dome wall is thinner relative to other areas of the bladder, and any perforation there would have unforgiving consequences. And then bowel would be in close proximity. So, if your electrocautery current settings are high, then there is possibility of transmural transmission of the current. So once you understand what your real problems are, solutions are relatively straightforward. So your basic problem was distance in the dome. So if you just ask your assistant to press suprapubically, that brings dome closer to you, and that is actually the most powerful way, to overcome this complication. The other area is, if you don't want to over distend the bladder, this not only takes the dome away and also thins out the bladder for you. So like other speakers have said, use continuous flow resection apparatus, and I have made this quite large. Don't over distend. That is very, very, very important. One tip that we practice is, you can attach a suction tubing to the outflow channel of the resectoscope, and that would allow you, high flow irrigation while also keeping the bladder low and distension. You basically, tip is, keep the bladder filled to half its capacity. About kinematics, like I said, the posterior wall near the equator, that has actually the worst kinematic angles, and you need to follow the curve of the bladder when you're resecting that. So this is where I would say, yes, you need some experience, but then it isn't as difficult. You just be experienced when you are handling that kind of an area. There, Mark Soloway calls. So you see this cutting loop here. What he has done is, you change the angle from a 90-degree to 45-degree. He likes to call it as posterior wall bladder loop. This is one trick you can have in your armamentarium to resect the posterior wall. Olympus, with its bipolar TURBT set, it gives you a customized loop for the posterior wall. You can see like these four loops here. They come in different thicknesses, different loop sizes. If you want to cut bigger tumor, you take a bigger loop size, and if you want more precision, like Dr. Ramesh said, we prefer, thinner loops which have been worn out actually after many TURPs. Now, another thing is, sometimes like most of the people would recommend that you cut from one side of the tumor to the other side. But in certain difficult locations, mowing technique may be more preferable, where you start cutting from the center of the tumor first and then approach the periphery. The logic I'll explain in the video why it is particularly preferable. Now, in dome, another big problem that you will face is that of air bubble, unique to dome. So this wonderful paper was published in 2014, and they gave this very useful tip. What you can do is just point your resectoscope towards the dome, close the outflow, open the inflow after disconnecting the irrigation fluid, and let the air and fluid come out. So multiple studies after this in UK have also validated this, that yes, it works, and we have also personally used this. It's a very useful tip. Also, make sure you don't introduce air in the first place. Like if your sister is giving you LX and it has half filled, don't, just avoid all those things. So keep keeping resectoscope be close to the tumor. It directs the jet of irrigation fluid towards the tumor, also displacing away the air bubble. So that is another useful tip while to handle these air bubbles. And naturally, if you are close to the tumor, you will use small excursions of the cutting loop, and that also increases your control of the resection. And remember that you frequently emptying bladder is not a time waste, especially when you are resecting the dome. because you won't have the explosive gases accumulating there, which can, assume dangerous proportions. Recently, people have modified the resectoscope to make a channel for a continuous suction apparatus to be attached, and I think we will soon have a commercial version of this available to constantly suck the air bubbles out. There are consequences to having air bubbles, oncological consequences to having air bubble in the dome. Suppose you have resected the tumor and left an air bubble there, and now you are giving post-op chemotherapy, immediate adjuvant. So that chemotherapy won't reach that area of the dome, which is, behind the air bubble. Another thing is people have found that voided cytology is positive more in patients who have got bubbles remaining at the dome at the end of the procedure at day one. And we also know that if voided urine cytology is positive by day three, then it has higher association with recurrence later. So yes, air bubble at dome has oncological consequences also. So now I'll quickly move on to the case. So ours was a 74-year-old male with a presenting with hematuria and a 3 by 3 centimeter mass at dome. MRI showed a mass at dome with transmural involvement with a small area of extravesical extension, pyrites 5. So this itself, tells us that what we want to achieve in that surgery. We wanted to basically maximally debulk the tumor and then achieve muscle in the specimen. So here is the cystoscopy. Now, as Dr. Gagan Prakash said, like in the trial that he mentioned in the end, appearance of the tumor at the time of cystoscopy also carries very high sensitivity and positive and negative predictive value in differentiating NMIBC versus MIBC. If you look at the appearance of that tumor, it was clearly solid. So MIBC is highly likely added to MRI pyrites 5. Yes, you have. Now look at the resection. We have started with the central area of the tumor, not from the periphery. This is mowing technique. Now, why is it important is because later on after resection, the bubbles will accumulate more in the central part of the tumor, which is, right at the top. So if you resect this first, then you don't have to bother too much about bubbles later. Now, obviously, you can't go on resecting endlessly there because you don't have really an area of appreciation of muscle there, but it's a good area to start. Now, as we move away from the center, gradually later, now see, we have moved away from the center. Another thing that you can notice that as you want more precision there, your excursion of the loop, it was large initially. Now, as we are moving towards the periphery near the posterior wall, I am taking the loop less and less further away from me. It's more close to the resectoscope beak. That is also displacing the air bubbles that are accumulating in the procedure away. So this adds more precision as we approach posteriorly. Now, um, now I am approaching the periphery of the tumor. I didn't start there first. You can see the assistant also is constantly applying pressure on the dome. That is one area which is outside the video, but that is very, very important. So he is constantly pressing it down, and that is how I'm able to resect it with control and precision. So here we are resecting as many solid areas as we can. It isn't bleeding as much, thankfully, which is nice. But again, I'm close to the tumor and I'm having full control while I'm resecting this. Um, Now, as the resection will proceed, naturally air bubbles will accumulate and they will, obscure your view. And as like I said, empty them. Don't keep resecting while they're like now. So now I just emptied the bladder. I used the technique that I showed, opened the inflow, disconnected it, and let the air come out while the outflow was closed, and again started resecting. Now, when I have gone in the second time, as I'm approaching the central area again, because now I have already resected quite a part of tumor, I have changed the angle of the loop. I don't know if you could appreciate. Now it is more acute. Earlier it was more of 90-degree because now I want less of a tissue to come in each excursion and resection that I'm doing. So the loop is more acute. Now, since like I said, our main intention that time was that maximum debulking because we already know it's a T3 kind of disease, virus 5. So that is achieved. Muscle is there. Thank you.
Thank you, Jitin. And just one point, when you are resecting the dome, the resectoscope is anyway turned the other way around. So even the uh, exit allows the air to pass out because it's the other, it's directed
Yeah.
upwards.
Yeah,
So you
yes,
don't have to
that is.
disconnect the inlet and to twist the resectoscope back in that post.
I totally agree, sir.
Okay.